All right, so today our first lecture is going to be about the foundations of nursing practice and health assessment. So we're going to be looking at the nursing process, the steps of a health assessment, and the clinical judgment model, which you'll see as CJM or CJMM. So the nursing process. You are going to need to know both the nursing process and the clinical judgment model. So this is really our basis for thinking like a nurse. First, we're going to work through this nursing process and we're going to go in more detail coming up. This is just kind of a brief overview. So first step is assessment. This is where we're going to establish a database or gather all that important information on our client or patient. So throughout this and the program, you may hear patient and client intertwined. That is because on the NCLEX, when you go to test to get your nursing license, they change their verbiage from patient to client. So on your exams, you will be seeing client throughout the program, or you should be. That is the same as the patient. In assessment, you're also going to be collecting that subjective and objective data throughout the assessment, which we'll get into more detail as well. And this is where you start to recognize those cues that may be important or relevant to why the patient is going to be seen. Next, you have diagnosis. So this is where you take the data that you collected in your assessment and you're going to make a professional nursing judgment. So that's when we're going to start analyzing the cues. So we're looking at what that priority concern is for our patient. Then we go into planning. This is where we take that priority problem and develop outcomes to solve the priority problem. Then you have implementation. This is where you're going to take action. So you're going to actually do the interventions to help achieve those outcomes that you made in planning to solve or attempt to solve the priority problem, which you identified in diagnosis. Then last, you're going to evaluate. So in evaluation, once you have acted and implemented your interventions, you're going to see if those outcomes were met or if revising the plan of care is needed, which is totally okay. So then this is the clinical judgment measurement model. You may also hear this as clinical judgment model, CJM, CJMM. They're kind of intertwined throughout your textbooks and what you will learn. Again, you'll need to know these 6 steps. So this is your clinical judgment model is going to be an expansion or more detailed of the nursing process. So we're going to be focusing on the critical thinking and decision-making aspects with emphasis on cognitive skills and processes nurses use to make their clinical judgment. The nursing process is going to focus more on structure, symptomatic approach, or not symptomatic, but systemic approach to the patient care, whereas this is going to be more in depth with your clinical judgment model. They are both essential, the nursing process and the clinical judgment model. They're important for safe and effective patient care. So when you go to clinical, you will see on your what we call a CET or a clinical evaluation tool. That is how we will assure that you're achieving the learning outcomes for clinical. They are going to align with the clinical judgment model. So the 6 steps are recognizing cues, being able to analyze the cues, prioritize hypothesis. So where do I start? What's the most important? Generating solutions. What can I as the nurse do? We then take action. This is what will I as the nurse actually do? Whereas generate is what can I do? Taking action is what will I actually be doing? And then lastly, you have evaluate outcomes. Did it help? So this right here is how do these 2 models align? How does the nursing process and clinical judgment align? So I tried to keep them in color coordination. So assessment is going to align with clinical judgment model, the recognizing cues. Diagnosis is going to correlate with analyzing cues and prioritizing hypothesis. Then your planning is going to correlate with generating solutions, implementation to take action, evaluation, evaluate outcomes. So then how do we think like a nurse? So we know that framework, the two frameworks, the two models, but now what are these other terms? So how do we really start to think? So we must be able to, as nurses, um, make clinical decisions or have that ability for clinical decision making. And then also we need to be able to critically think. So critical thinking and clinical decision making, those two together equal that clinical judgment. So clinical decision making, so that first column on here is when you're going to use your judgment in analyzing the clinical problem. Then you're going to apply scientific or evidence-based practice and the nursing knowledge you have to choose the best course of action for that patient. So this is when you're going to be walking through the nursing process clinical judgment model during clinical decision making. So the nurse will recognize and analyze cues, prioritize hypotheses, generate solutions, take action, and evaluate. Now, critical thinking, I try to think of this as you are the investigator. So you put your investigator hat on. This is when we need to really get to know our patient and understand them. So we will be taking information provided by the patient to further understand them. We're going to deep dive into their condition. And is there any information that we are missing? Do we need to ask additional questions? So those additional questions could be, why does this patient have this condition? Are these signs and symptoms that they have? Are they expected? What is known about the client's condition? Do I need more information? What can I do for this client to better their care or treatment? Then clinical judgment, like I said, I put a little star next to it because that is really the ultimate thinking like a nurse. That's when you're taking the clinical decision making and you can critically think and combining those to clinical judgment. So this involves that knowledge base, so based on clinical decision making, critical thinking, and then another component that we haven't talked about yet to really enhance the clinical judgment is simply experience. The more experience you have, the more knowledge that you bring to the table in your clinical judgment. So the nurse in clinical judgment will assess a situation, identify that priority, generate the best evidence-based practice solution, and make the best decision to deliver patient care. So this is an example of the nursing care plan where you really start to put those thoughts that you um, have from obtaining and going through your nursing process and clinical judgment model to really see what that patient's highest priority is, the subjective data and objective data that supports the reasoning why you chose that as the highest problem or priority problem for the patient. You'll make outcome for the problem. So it's that SMART goal, which we'll talk about in a little bit. Your interventions and the rationale for each. And that is, what are you going to be doing as the nurse? And then evaluation, did we meet an outcome? And if not, again, that is okay. And we'll go through these step by step. So let's start with the very first step. We need to do an assessment and or recognizing cues. So that is your first stage in nursing process and clinical judgment model. So what is the purpose of an assessment? So the purpose of this is to really collect holistic data to determine that patient's health and then to make a professional judgment or decision. We do this through steps of an assessment. So we will, as the nurse, collect subjective and objective data through our assessment. We'll validate that data to make sure that's accurate, and then we will document it. What is subjective data? All right. So first we'll set it will obtain subjective data. So subjective data cannot be measured directly by the nurse. That has to actually come from the patient. So it's subjective data helps us really guide further questioning, helps identify that priority concern, and really does help contribute to the nursing diagnoses. So how can we obtain objective data? So like I said earlier, it needs to be from the patient. So we will do like an interview. We will be communicating with our patient. There are certain times that information can be obtained from a family or significant other, preferably a healthcare power of attorney. And that would be when a patient cannot speak for themselves. So they are not able to give us personal information, symptoms, desires, beliefs. That is when we can go to a family or significant other, preferably a healthcare power of attorney. Now, how do we as nurses best elicit or get subjective data from the patient? There are certain questions that we would have to ask and certain styles of questions, which we'll talk about in a little bit, but specifically utilizing open-ended questions. So that helps us really clarify information from the patient, and they actually need to like give us a story essentially. So for instance, we can say, can you tell me more about the pain? Or what brings you in today? That is going to have an open-ended, this open-ended question, and it'll open up the patient to be able to respond as they please rather than short, pointed phrases. It's important for us as a nurse that we also are performing and doing active listening during this time and allowing that patient or client to respond to us. Then, what are some examples of subjective and collective data? So it's what are their beliefs, ideas, values, their personal information. So verifying that name and date of birth, those are things that they need to tell us. We can see it on a chart, but we still need to verify with the patient. They're going to be able to tell you sensations, symptoms, feelings, perceptions, desires. So things that we cannot actually assess or be able to tell without the patient telling us. So I like to put subjective equals says, so they both start with an S, and that's how you can remember that. And some examples are, I feel dizzy, my pain is an 8 out of 10, I feel anxious about an upcoming surgery, I prefer to go by such and such. So then what is objective data? So objective data is information that is measurable, observable, and verifiable by the nurse or healthcare provider. So this is collected through our physical exam, through any diagnostic testing, such as labs or imaging, vital signs, direct observations. So an example of a direct observation is saying, a client comes in and they have been feeling pretty anxious. Objectively, we may see that they have tachycardia, which is an increased heart rate, inability to sit throughout an assessment, repetitive tapping of their fingers or shaking of their legs, fidgeting, etc. So when they state, I am feeling very anxious, that's subjective because that is what they're saying, but the objective findings are what we are actually seeing. So what role does objective data play in an assessment? It validates or supports subjective data, provides that baseline measurement, and then helps identify those priority concerns. So now that we have done our subjective and objective data collection, we need to validate and document. So what is validation? That is where we are confirming that the information that is being collected is accurate, complete, and consistent. So the purpose of validating the assessment findings is to ensure that we are avoiding errors or misinterpretation of what the client is telling us or what we are finding. It also ensures that the nursing judgment and care decisions are based on factual, reliable information. Clarifying discrepancies between subjective and objective data can also be found during that validation. So if a patient reports a 9 out of 10 pain, on their subjective data collection, but objectively they are seeming very comfortable, they are having an ease of conversation, then that would be something that may be a discrepancy. Of course, we do have patients that have chronic pain. And so they may state that they have a 10 out of 10 pain, but appear to us as they are comfortable. So we do need to remain unbiased throughout this, just to make sure what other findings maybe do they have. Do they have an increased heart rate? What's their blood pressure? To check. Validation as a whole, it helps prevent misdiagnoses, inappropriate interventions. It also promotes individualized evidence-based practice care and enhances safety by ensuring we're providing the nursing care that is based on correct findings. So that's why we need to validate. And then we have documentation. So this is where we're recording all of the collected client data, so objective and subjective. We want to ensure that our documentation is very clear, timely, and legally documented. So what's really the purpose of documentation? That is documentation is a legal protection for the nurse. It shows what the nurse has observed, what they did during their shift. It is very well known. You'll hear everybody say it throughout the program. If you didn't document it, you didn't do it. So when we talk about legal in a few weeks, legal implications, so we can go to court several years after we take care of a patient, if that patient or their family decides to, take legal matters. So making sure that you do document so that in 5 years you do have a yes, I did do this, or no, I didn't because I didn't document it. Also, it provides a reference for evaluating progress and outcomes. If you didn't document it, how do we know what they were like previously or at their baseline and how they are either improving or declining, if we don't have a record of it? Also, documentation helps support quality improvement, research, and billing and reimbursement. If it's not documented on there appropriately, then insurance may decline coverage. Then how do we collect subjective data? So what do? We will conduct an interview and a health history. So with that, there are 4 phases of an interview process. You have your pre-introductory, introductory, working phase, and closing or summary phase. So in pre-introductory, that is everything you're doing before you're actually going in to see your patient or your client. So we're going to be reviewing their chart, identifying maybe their medical concerns. Sometimes if you're in the outpatient world, you'll have somebody like an MOA or a PCT that will say, or those are patient care techs, and medical office assistants. So they may say, oh, the patient's here today for this, and this is what their complaint is. So you're kind of getting a general idea of what's going on before going into that patient room. This is also inpatient when you are getting like a report on that patient. You'll be reviewing progress notes to see what's been going on, reflect on your personal biases as well. So if you do have a client situation that you may feel biased about, then you want to be able to reflect before you go in there so that you can go in there and provide the best care and be as unbiased as possible. Then you have introductory phase. So that is where you're going to introduce yourself. So, hi, my name is Faith. I'm going to be your nurse today. You'll explain what will be happening. So I'm going to be doing a physical exam. I will be asking you several questions. Then you want to ensure also confidentiality. So with that, it's always good to let your patient know, just so that you are aware, anything that is said between me and you will remain between me, you, and your healthcare team. We do have HIPAA, and that is where we cannot share information outside of that healthcare team for that patient. We also want to ensure that they are comfortable throughout the entire interview. And then you really want to be able to develop a rapport and a trust with your patient, especially before you start getting into asking them a bunch of questions and doing a physical exam. So then you move into your working phase. This is kind of when you're asking all the questions. You're really seeing what is going on with your patient. So why are they there? What is their health history? So what's the history of their present illness? So if they're coming in with chest pain, we're going to start asking those questions of, when did that chest pain start? What does it feel like? And we're getting a more history of that present illness that's going on. We want to know their past medical, surgical, and family history. We'll do a review of the body systems to see if there's anything occurring that is different from maybe their baseline. You also want to look at lifestyle and health practices. So how is this illness or what they're presenting with affecting their activities of daily living? So those things are, can they wash their dishes? Can they do laundry, clean the house? Things that they normally can do, is it starting to interfere with? And then you also want to ask about, are they married? Do they have kids? Who's involved in their care? Which we'll learn more about throughout this slide. But then also when you guys go to lab. Then you want to see their developmental level. So we want to make sure that we are educating and speaking to them at their level, and we're not utilizing like medical jargon. Lastly, you have your summary and closing phase. So this is the very end. You're summarizing information, validating any problems or the goals that the patient has expressed, and then you want to discuss the plan. So you may not be able to do anything right at that moment, but you can simply say, I'm going to go speak with your healthcare team regarding this concern, or whatever you plan on doing, and discussing that plan with them, always keeping your patients involved in their care. And then it's always nice to ask about anything to add or any questions before I leave. So this is your cold spa. So we utilize the pneumonic cold spa, COLDSPA, that will help determining that history of present illness. So this is a little screenshot of the cold spa subjective data collection that you guys will do in lab. And it breaks down. So you have your cold spa, you're asking about character, onset, location, duration, severity, pattern, what makes it better or worse, and then some associated factors. Again, you'll learn more of this in lab. And then you start going into fever, allergies, and then we start going into their past medical history, surgical history. Have they had these symptoms before? Family history. And then we make sure that we get their medications that they are on, including over the counter and herbal, their lifestyle practices. So those are those questions about their lifestyle. What was their job, or what are they currently doing for work? Marital status, exercise, those ADLs, diet, smoking, vaping, and then we always end, as previously discussed, with anything else to add or any questions. So then there are different types of assessment. So you will need to know this. So you have initial comprehensive assessment. So this is a complete detailed assessment. This typically is going to occur when the patient first comes into a healthcare setting, whether that be admission to the hospital, the first clinic visit, seeing like a primary care provider or a specialist, also your first home health visit. So that very first time wanting to get a baseline. So that is what the purpose is to establish that baseline for that patient for future visits. We want to really have that foundation for individualized care. So at this initial comprehensive assessment, we would be doing a full health history. So we're going to be asking all the questions, and then we will do a full comprehensive head to toe physical exam. Then you have your ongoing and partial assessments. That is when you're going to be reassessing the client status. So we're going to want to see if there's any changes from the initial time that we saw the patient. Say reassessing something that is abnormal. So for example, you have a patient that you had listened to, you had done an exam on, and their lung sounds were not sounding so good. There was some like crackles, wheezes in the lungs bilaterally. So then the physician orders a nebulizer treatment of albuterol. Well, the hope is that after they have the med, after so long, which you will learn in pharmacology, that then their lungs will start to sound clear. So we will then do an ongoing or a partial assessment to just check those lung sounds. Did the lung sounds improve after the neb treatment? You also then have like your blood pressure patients, patients that have hypertension. So then once we check a blood pressure, maybe it is elevated, say it's 150 over 90, then they have a PRN or maybe even a daily dose of a hypertensive medication, antihypertensive medication. Then 30, 60 minutes after administering that medication, we're rechecking that blood pressure. That would be an ongoing or a partial assessment to see did that blood pressure go down after administering those medications. A focused assessment, that is an assessment that is really concentrated on a specific problem within the body. So this is to address identified health concerns. That's the purpose. When do we do a focused assessment? So if we have a patient that's coming in and whatever their chief complaint is or their main concern. So for instance, we may ask, what brings you in here today? And they're saying, I'm having a lot of shortness of breath. And then we go through the interview. Well, then we need to do a more focused assessment. They're short of breath. I'm thinking lungs, so I'm going to want to do a respiratory assessment. This can also, a focus assessment, be done with somebody that has a known problem that we are wanting to reassess them on. So maybe they're in there for chest pain and they were diagnosed with congestive heart failure. Well, then we may want to do a focus assessment on the cardiac system at a later time to evaluate how they are doing in their health, uh, in their congestive heart failure management. Then lastly, you have an emergency assessment. So this is a rapid, focused assessment that is going to be done during life-threatening situations. So the purpose of this is to provide a quick eval of immediate threats to life. So we need to really do this in those urgent settings that the client would need an urgent intervention. So let's think of our emergencies. That would be a cardiac arrest or a myocardial infarction. Someone comes in, they have massive trauma. They were in an MVA, which is a motor vehicle accident. Maybe they're in severe respiratory distress. They got stung by a bee and now they're having anaphylactic shock. These are emergency situations, so we're going to be very focused. We're not going to be taking our time and going through all these, questions and assessments. We're really honing in on the issue that is right now. So for instance, you have somebody that is coming in with facial drooping, slurred speech, weakness on one side of their body. I'm going to start thinking, oh, are they having a stroke? We are then going to initiate a stroke protocol depending on where we are at, get them to CT, do things with them that are very rapid and focused. All right. It's also really important for you guys to have communication awareness when you're communicating with your patients. So we have nonverbal and we have verbal communication, like cues, communication things. So with nonverbal, you've got your appearance. So really making sure we are looking professional, neat, making sure that we have neat and clean scrubs or dress attire, that we always have our name badge, and that we are just well maintained in our appearance. Next, you have your demeanor. So are we professional? Are we focusing on that client? We are not walking into the room laughing, muttering, or being very distracted. And then throughout our interaction with our patient, making sure that we are avoiding distractions as well. You have facial expressions on there too. We want to try to remain as neutral as possible during our interactions with our patients. This was a little bit easier during COVID times when we had a mask on, and then it kind of transitioned to taking our masks off and being a little bit more difficult. So we do need to be aware of that. Then you have your attitude. We have the professional obligation to remain non-judgmental, never to feel more superior than our patients. We are all equal human beings. We just may have that nurse title behind our name or in front of our name. And then you have, I think, two of the most important out of all these are your silence and listening. So periods of silence, when you really get to allow that client to reflect and organize their thoughts. So if we ask them a question, give them, 3 to 5 seconds to really think about what they want to respond with or how they want to reflect on what you have just told them. And then on the other hand of that is listening as well. So really one of the top two important things to do is always to have that listening ear. This is going to make sure that we are able to collect complete and valid data for our patient. Eye contact, not too much, not too little. Also making sure this is going to come into play with certain cultures and how they feel on eye contact. We also want to make sure that we do keep a personal space, that we are not too close to them, but that we're also not distancing ourselves. And then lastly, really looking at that standing versus sitting. If the client is sitting down, I do not like to stand, and like that kind of shows superiority, or that you are literally talking down to them, and that is just not something that will make them want to open up and have a conversation with us. It will not build that rapport that we're looking for. So try to stay on their level as much as possible. And then with verbal communication, there's different ways that we can ask questions and things that we can provide to our patient. So open-ended questions. This is where we're really eliciting feelings and perceptions. So those open-ended questions will begin with how or what. So how have you been feeling today? What brings you in? It's very open-ended so that the client patient can get and tell us their story, tell us what is going on, rather than close-ended. And close-ended questions is where we are just wanting to obtain facts, focus on specific information. That typically begins with when or did, like when did your chest pain start? This will also help in certain situations that you really need to keep the conversation on course and remain focused, or being able to redirect, or you can ask a close-ended question that hopefully gives a minimal response, but is also listing appropriate information. Well, next you have a laundry list. So this is when we provide a client with difficulty describing symptoms. We provide them with like a list of how to maybe describe their symptoms. The most common that you're going to have for a laundry list when you're going to be providing it is when they're describing any type of pain. Pain is just a hard one to sometimes pinpoint on describing it. So many times I'll ask, like, is your leg pain, does it feel severe, dull, sharp, aching, cutting, piercing? We start giving those adjectives, and that would be a laundry list when we're giving different options on how to describe something. And then you have rephrasing. So this really is going to help clarify information. You and your client will be able to reflect on what is being discussed. So for instance, the client comes to tell you she's been feeling fatigued and has this decreased appetite for 2 months, and she's really scared that she's going to have some life-ending disease. You can then rephrase that information. So, are you thinking you have a serious illness because of the fatigued and decreased appetite? You're kind of flipping the words around. You're just simply rephrasing it just to make sure that you both are on the same page and clarifying that information. You also have well-placed phrases. That's going to really encourage the client to communicate with you or continue communicating. So this is going to also show them that you're listening. So these are, yes, I agree. Those type of statements are well-placed phrases. Inferring, that is when you notice like what your client is saying and what you are observing are different. So your subjective versus objective are different. Um, and it can even be so much as, the client is saying, I'm having leg pain. But you notice, and they're just saying leg pain in general, but you notice that they are not putting any weight on their right leg. So inferring, we could say, it seems like your right leg is causing you pain. Is that correct? And so that we can infer in that sense. Also providing information. So we want to always make sure that we are answering their questions or concerns throughout their exam. It is okay to not know the answer though. So if they do ask a question and you are not sure, I'll just talk with the provider and see, what we can do, or how I can answer that question, or maybe grabbing another nurse, grabbing, in your guys' situation within school, I'm going to grab my instructor, and that is absolutely okay. And then clarification or clarifying, that is when you, as the nurse, may say, I'm not sure that I understand. Could you please give me an example? Or can you please explain that better to me? It is okay to ask for clarification. We want to make sure that they get the best care. Communication things to avoid. I kind of did talk about this on the last slide. So certain eye contact, avoid extreme eye contact. Also just being culturally aware that some cultures have a different comfortability level than you may have with eye contact. Also making sure that we are not distracted and that we watch our distance. So we really don't want to be physically too far. We also don't want to be over top of our patient. We want to avoid mental distancing as well. So that might sound like, oh, what's mental distancing? Well, mental distancing is like when you are thinking, I've got 5 other patients I need to go see. I've got this, my best friend's calling me about this. My husband needs help with picking up the kids. You're thinking of all these other things when you're in the patient's room. And we really need to try to not do that and have our full focus on our patient. Also, standing, I did discuss that. We want to avoid being above the client. And then for verbal communication, we want to make sure that we're not having any biased questions. So, biased questions would be like, you don't smoke, do you? Like that's kind of a biased question. It could also be a leading question as well. So leading question that along with rushing an interview and reading questions directly off of paper are things that we need to avoid. And as you guys are learning, you may need to reference your sheet or the questions that you need to ask, and that is okay. Just make sure that you are cognizant of making some eye contact with the patient and making sure that your back's not to them, that you're still trying to interact with them. All right, special considerations during the interview. So with our geriatric population, they have physical and sensory changes as they age or as we age. So speech may be a little slower, same with their cognitive abilities may be slightly slower than a 20-year-old. So we want to make sure that we speak slowly and clearly. That is not to be drawn out. We are not speaking at a snail's pace, but making sure that we are not rambling or talking too quickly. They may not be able to stay stay with us. Minimize position changes. As we age, we do have difficulty, going from one position to the other, and it may take us more time. We just want to minimize that as much as possible. Also, we want to utilize a lower tone of voice. In our elderly and as you age, your high frequency hearing is going to be lost first. So remain at that lower tone of voice if possible. We want to always make sure that there is adequate lighting and minimal background noise when we're doing our assessment, just because we may have somebody that is hard of hearing. And we may have someone that doesn't have the greatest vision, and that lighting would be beneficial. Who wants to read in the dark? And then allow extra time for response. As I said, their cognitive level may be slightly declined. And so they're not going to respond as quickly because processing and recall is going to take a little bit longer. You may want to consider any educational points you give them, that it's in larger print, easier to read. And then regarding cognitive and memory, we do want to make sure that we are assessing orientation and cognitive function fairly early in the interview. We want to also avoid any rapid topic changes, keep our questions simple and focused, and then if needed, or if we believe that there is a memory impairment that is occurring, we can validate information with a family or a caregiver. Also, psychologically and emotionally in our geriatric population, we do need to have that patience and respect because they are our elders. And then in certain cultures too, that is even a higher respect and honor as you age. We also want to make sure that we are promoting autonomy and independence within our geriatric population and allowing them to make decisions. Allow them to be involved in their care. As we age, there's many individuals that will feel like they are having choices being taken away from them. Maybe they've lost their driver's license, or they can't live at home, or their kids are trying to get them to go into a nursing home. Well, that's a lot of loss of independence, and we want to promote that as much as we can at the bedside or in an office setting. And then we want to be mindful of loss, grief, and social isolation. As we age, there is going to be an increase in that loss, which would lead to potentially grief. And then there may be some social isolation. Like I said earlier, maybe they don't have a driver's license and their kids live out of state. Well, how are they getting from place to place? Do they have neighbors that they talk to? Do they get out? Do they go to dinner with friends and stuff? That might be not as common. Culturally, we want to make sure that we are aware of differences in eye contact, touch, personal space, and gestures. If need be, and someone is speaking of a different language, then we would need to utilize a professional interpreter. Here at OSF, we have like little tablets that then we can pull up a really wide range of different languages, and even from different origins and where that dialect is from. And then we want to actually utilize that. We would prefer not to. It's not good to take family members and have them translate, because we cannot guarantee that they're not falsifying what the patient is saying. Even other healthcare professionals, we don't ideally like to do that. You can actually, if you are bilingual, you can get a certification that then would make you a quote unquote professional interpreter, and then you would be able to. Also, when we're communicating with different cultures, we want to make sure that we're avoiding medical jargon. That's also just going to be kind of across the board with anybody. And we use culturally relevant examples for those patients. There's also may have different beliefs on health and illness. So we want to be aware of, what are their healing practices, remedies, spiritual beliefs. We need to show them respect by asking these so that they can then feel comfortable in their care. And we never want to dismiss them or dismiss their beliefs. And then as much as we can, let's also incorporate those culturally accepted approaches when possible. So maybe they, in their culture, they involve their family elders or religious leaders into their healthcare decision making. Well, then let's make that accessible for them if that is what they wish. Also, family dynamics may be different. It may not be the same as your own personal culture. And then we also need to remain very unbiased and avoid assumptions or stereotypes. It's okay, and I enjoy doing this. I will ask very open-ended questions like, can you tell me more about your culture or religious practices that are important for your healthcare? What can I do for you to make you more comfortable? And really being aware of that. And then also passing that on from nurse to nurse so that everybody is aware of that. That this person wishes to have these cultural religious practices done for their healthcare. Also, then we have emotional considerations. So this is really creating a safe environment and observing nonverbal cues because not everyone is going to be calm and friendly when we're taking care of them. Some patients are at their absolute worst pain that they've ever had. Nobody wants to be in the hospital. And so agitation can be increased, it can occur along with other emotions. So going into emotional variations and how do we as nurses approach different situations and different types of emotions? In general, we want to remain professional, empathetic, and neutral at all times. We also want to utilize therapeutic communication techniques. So these therapeutic communication techniques you'll learn more throughout the program, especially when you get to your mental health rotation. But this is simply active listening, like we talked about, open-ended questions, and being able to reflect on what is occurring. You also want to observe nonverbal cues and then ensure privacy and safety for both you and your patient. And then recognize when to pause the interview or when you will need to complete your evaluation later. And that would typically be with any mental health or safety concerns. So, your first patient that we'll talk about would be maybe your anxious patient. Typically, how they will present, they'll be very restless, fidgety, possibly have like a rapid speech, difficulty focusing, and they frequently need that reassurance. So they have this reassurance seeking, like, am I doing this okay? Is this all right? And that would be your behavioral cues for somebody that's anxious. So as a nurse, we want to make sure that we are keeping a calm and quiet environment, that we're reducing any extra stimuli and distractions. We want to speak very softly and slowly. We want to use more short, simple explanations. Avoid medical jargon as that can sometimes increase that anxiety. And we really want to be able to explain each step of the interview or the exam and talk them through what is going on and what you're going to be doing. We also want to encourage expression of feelings. So can you tell me what worries you most today? And then you want to ensure the client that you are doing this because ... So explain what you're doing and why. Avoid rushing or showing any impatience and potentially even allow some extra time with your anxious individual. Then you have angry or maybe even hostile clients that you'll take care of. Typical behavior cues, you're going to see like clenched fists, their voice may be raised, they'll have more of a defensive posture, some sarcasm, glaring, abrupt, or very dismissive tone. So, first and foremost, with somebody like this, we want to make sure that we are safe. So, we maintain a safe distance and we have a clear exit route. So, we never want our back to that patient. We want to make sure that we are right next to a door if we need to get out of an unsafe situation. We want to remain calm, composed, and respectful, and we do not argue or match that anger that they have. That is just going to only escalate them. And it's okay to acknowledge their feelings as well. You can simply say, I can see you're upset. Help me understand what's making you angry or upset. Um, and that's going to help open up where they can then tell you what is going on. And then we also need to just listen actively and allow them to vent verbally without interruption. Now, if it starts to get where they are starting to escalate more, then we need to make sure that we're setting those clear, firm, and respectful boundaries with them. Avoid touching this client. Again, that kind of goes hand in hand with maintaining that safe distance and safety and keeping a non-threatening stance. So don't sit there with your arms crossed or looks like you are just as upset as they are. If aggression or that anger escalates, then it is absolutely okay for you to end the interview and seek assistance and get out of the situation. While we want to always take care of our patient, we also need to keep ourselves safe in those situations. So then you have your depressed clients. They may appear to have more of a flat affect, poor eye contact, a very monotone voice, a slower speech, and maybe have vocalized hopelessness or helpless type statements. So with this, you want to have a quiet, supportive, and non-judgmental tone with them. Also asking those open-ended but gentle questions. So not like, well, why are you feeling this way? Maybe how have you been coping lately? And not as like judgmental or assuming. Also avoid excessive cheerfulness. It can feel very dismissive, and that individual that may be having those depressed feelings may be like, wow, she is just, or he is just super cheerful. That makes me really sad. And so we don't want to do that. We want to show empathy and, say like, that sounds really difficult and not go, oh, that sounds really difficult. Well, do this and you'll be happy. Like, we want to just show that empathy. And then a big thing with our depressed clients, we want to assess for risk of self-harm or any suicidal thoughts when appropriate. That is going to be a big safety factor for those individuals. We want to also avoid making any type of promise. So we don't ever want to say everything will be fine. We don't know if everything is going to be fine. We have no idea. Instead, focus on support and resources like I am here. Um, that sounds really difficult. How about would you be willing to talk to a counselor or whatever other resource you're comfortable with sharing? And then you want to encourage the client's strengths and reinforce positive coping strategies. Then you have manipulative clients. So behavior wise, they may try to control the conversation, guilt trip you, utilize flattery. They'll have inconsistencies in their stories. And then they'll have like this quote unquote splitting behavior. They're going to start like trying to pit staff against each other or going to multiple different people to see what they can get out of, one nurse over the other. Teaching points and nursing approaches for this. When we are talking with them, we want to make sure that we maintain a firm and consistent boundary with them. Be clear on what you can and cannot do. So you want to remain objective and factual and avoid any emotional involvement as well. We do not want to reward manipulative behavior with any extra attention or exceptions. That is only going to fuel that manipulative individual's drive to be manipulative. Collaborate with healthcare team for consistent responses. So you need to make sure that if, they're asking for more pain meds or they're wanting, a special drink or something, and they've been manipulative in the past and you need to be aware of that, then you were passing that on to other nurses. We're letting our techs know, we're letting anybody that's involved in their care be aware of that manipulative behavior. And then you have lastly your seductive clients. So they're going to be more flirtatious. They're going to have inappropriate touch. And that can be any type of touch that's really uncomfortable for you. There's no specific inappropriate touch. There is inappropriate touch, but maybe you don't want that a hand on the shoulder or no, like you need to keep that boundary. That's absolutely okay. Someone that's seductive may have excessive compliments, suggestive clothing, or even a tone that they have with you. So for this, you want to maintain professional boundaries and a very neutral demeanor at all times. We don't reciprocate flirtation. We don't respond with any humor. That can actually just reinforce that behavior and they're going to keep doing it. We want to utilize a very formal communication and redirect focus back to the assessment. So we can say like, let's focus on your health concerns right now. Or we're doing a physical exam right now for the cough that you came in here today with. If the behavior persists, we need to address it directly, but also professionally. So you can say like, that comment makes me very uncomfortable. I'd like to keep our conversation professional. And it is okay for you to have that tone and to be very blunt with them. You want to ensure you want to ensure that maybe other staff members are present with you if that continues. So grabbing another nurse, whether it's the same gender individual or, maybe you want to bring in the opposite gender in there just to show that you're not going to handle the seductive behaviors. And then also make sure that you document, and that's going to be on any of these emotional variations. You want to document so that we are aware, the whole healthcare team is aware of what's going on. Now it's time for our objective assessment. The objective assessment, we have physical assessment that we will be doing. So in the physical assessment or the objective portion of your assessment, you'll have 4 cardinal techniques that you will be performing. So it's inspection, palpation, percussion, auscultation. It's going to be typically done in that order as well when you are assessing a patient, except for in an abdominal assessment, which we'll talk more later on in the semester. And in that assessment, we would do inspection, auscultation, palpation, and then percussion. So what is inspection? That is when we're going to observe the client's body and behavior. We're going to utilize the sense of sight, smell, and hearing. Mainly sight, a little bit of smell, and for hearing, it is more of what we're hearing without utilizing a stethoscope. So we're not doing auscultation. We're just hearing maybe they have a cough. We're hearing that cough, or maybe I can hear their shortness of breath because they're like gasping for air. Those are the type of things that can be involved in inspection. So why do we do this? We really want to get data on the client's general appearance and throughout their specific body systems. So for this, we typically will begin with a general survey. A general survey or generalized inspection is going to look at their overall appearance. What's their posture? How's their mobility seem? What's their hygiene like? What is their mood? Then we moved more onto our focused inspection of each body region. Whenever we do an inspection, we compare symmetry between sides of the body. So we will do bilateral comparisons. So what's that right arm look compared to the left arm? We want to observe color, size, shape, contour, movement, any lesions. Um, and then we also want to know any odors. That's going to really indicate any like poor hygiene, infection, and possibly some disease processes as well. We also will observe those nonverbal cues like facial expressions, affect, and this is an ongoing. Inspection is ongoing. It starts from the moment you really see that patient. And then next you have palpation. So this is when you utilize touch to assess body structures and detect temperature, texture, moisture, masses, tenderness, vibrations. We do this to confirm findings observed during inspection and gather additional data about underlying tissues and organs that we just cannot see. So for palpation, while you are getting ready to palpate, make sure you do high hand hygiene anytime we touch a patient before and after. Make sure that your hands are warm, clean, and that your nails are short. With the warm, you can just rub them together, or if your hands are naturally cold, just let them know. I do apologize when I palpate if my hands are cold. You want to make sure that you ask that patient to relax and communicate any type of discomfort that they have. So with this, there are different parts of the hand that you can utilize to palpate. So you can utilize your fingertips. So that's going to be more fine tactile discrimination. So that's more like feeling for texture, pulse, swelling, any lumps. Then you can utilize the dorsal side or surface of your hand. That's the back of your hand. We're going to be checking temperature. And then the palmar side or the palmar surface is the base. It's going to be like the base of your hand. Ulnar is going to be on the pinky side of your hand. This is when we're going to be assessing for vibrations or thrills. So we'll start with a light palpation. Light palpation is about 1 centimeter deep. It's really just to detect any surface abnormalities or tenderness. Then you do a more moderate, so a little bit deeper, like 2 to 3 centimeters. That one's not as commonly used. We typically do light and then deep. Deep palpations, I'd say, are it's about 4 to 5 centimeters deep is what you're going to be pressing in for that patient. I think typically, like in your abdominal assessment, you're looking for deeper structures. So like your liver, your spleen, kidneys, those type of things. While we are doing any type of palpation, you want to make sure that you are starting in the least tender and then moving to the most tender region of looking at your patient's facial expressions for any sign of discomfort. And then lastly, you have your bimanual. Bi is two, manual, like is more hands-on. So that's two hands that it can be utilized for like to check the liver. You can do bimanual on a breast exam. And that's when you're assessing size, shape, mobility, tenderness. Always before you start palpation, make sure that you are informing the client that you're going to be touching them. Remain professional, utilize a gentle touch. Of course, deep palpation may feel not as gentle, but still be as gentle as you possibly can. Avoid deep palpation in any areas that may cause harm. So if they have an enlarged spleen, an inflamed organ, we want to avoid that deep palpation. So next we have percussion. Percussion is going to be a physical exam technique in which the nurse or that we will tap on the body surface to produce sounds and vibrations. So it's going to help assess underlying tissue densities such as air, fluid, or is there a solid mass? It's also going to determine the organ bound borders or size. So for instance, like the liver and the lungs. And then you can utilize it to detect abnormal masses or areas of tenderness. And overall, it's going to help evaluate the presence of fluid or air in certain body cavities, such as the lung and abdomen. So what are the types of percussion? You have direct percussion, indirect percussion, and blunt percussion. So direct percussion is a tapping directly on the body surface with 1 or 2 fingertips. Typically, this is going to be done on the sinuses, on the frontal and maxillary sinuses to assess for tenderness. Indirect percussion, that's when we utilize the middle finger of one hand and we place it on the body surface and we tap it with the middle finger of our other hand. So this is most commonly done over the lungs, the abdomen, and to assess that liver. Blunt percussion is when we use the ulnar side of the fist or the hand to assess tenderness over those dense organs. So for instance, our kidneys. We'll test it on the posterior side of the patient. We'll do what we call a costovertebral angle or CVA tenderness. And what we do is we just place our hand down against the patient on that CVA area, and then we will blunt percuss with the fist of our other hand over the top of our hand, and we will be assessing for any pain in that area, which could indicate kidney inflammation. So then there's different sounds that we will elicit while we do this percussion. So you have resonance, that is going to be a hollow, low-pitched noise, and that's going to indicate normal air-filled lungs. So that's where you will hear it, and it's going to indicate healthy lungs. Hyperresonance, you will hear also over your lungs. It'll sound very loud, a lower pitch, and kind of a booming noise. This is going to indicate that the lungs are filled with too much air. So we'll hear this in our COPD patients and if they have a pneumothorax. Tympany, that is going to be typically done over the abdomen, or you will hear it over the abdomen. It's going to sound loud, high-pitched, drum-like. It's just going to indicate that there's air-filled structures in that region. So when you do it over the abdomen, you do percussion, you should hear tympany. That would be over like your stomach and intestines. Next, you have dullness. That's a soft, high-pitched, thud-like noise. It's going to indicate that there is dense organs or fluid. So this is going to be over more your dense organs that are your liver, your spleen, and then fluid-filled organs, such as like your bladder. So if your bladder is full, you would hear some dullness. And then you have flatness. Flatness is a very soft, high-pitched noise. It's going to indicate extremely dense tissue. It's very common to hear this over bone, but also can be heard over masses and tumors. So our last cardinal technique is auscultation. So this is the technique that we utilize to listen to body sounds. So we'll listen to the heart, the lungs, blood vessels, the abdomen, and we utilize our stethoscope to assess the presence, frequency, intensity, quality, and the duration of sound produced by these organs and tissues. So we want to be able to, why do we do this? We want to be able to identify normal and abnormal sounds throughout the body systems. It'll detect changes in function, such as like airflow in the lungs, a heart rhythm when you're listening to the heart, or any bowel activity in the bowels. And it also will help to confirm or refine findings from inspection, palpation, and percussion. So we utilize a stethoscope when we do auscultation. So for this, there's 5 pieces to that stethoscope. You have your earpieces. This is a soft tips that fit snugly into your ears, and they're going to help transmit sound from the tubing to the ears. It should fit very comfortably and securely to really make sure that you have a good acoustic seal so that you can hear appropriately. And you want to make sure you angle forward the earpieces toward your nose, which will match the ear canal direction so that you can hear properly. You also want to make sure that you're cleaning these earpieces regularly to help prevent any infection. And then you have your ear tubes. So this is the metal tubes connecting the earpieces to that flexible tubing. They're going to conduct sound waves from the chest piece, and they are usually made of a stainless steel for a really good sound conduction, and they can be adjusted for tension or fit if needed. You also want to make sure you keep these symmetrically aligned for comfort and optimal sound. Then next you have the tubing, so that's that flexible tubing. You get to have like fun different colors. It's typically made of rubber or PVC portion that carries sound from that chest piece to the ear tubes. This is going to transmit sounds while blocking external noises. And that is why it's in that like rubber or PVC portion. You want to avoid bending sharply or wrapping tightly. It can actually cause that tubing to crack. Then you would no longer be able to hear noises through the chest piece. You want to clean this regularly and keep away from extreme heat or sun. So don't hang your stethoscope in your car or leave it out in your car. Make sure that you are taking it with you. A lot of people have these little stethoscope cases that they take on clinical. Then next you have your chest piece. That is also called like the head of the stethoscope. It's the end of the stethoscope that is going to be placed on the patient's skin. You have a diaphragm and a bell side. They're what is the main sound receiving component, and we want to make sure we always keep this clean to maintain sound quality and infection control. So we do clean this between patients. We need to make sure that we are not spreading sickness to sickness from patient to patient. So then with that chest piece, you have a diaphragm and a bell. So the bell is going to be a smaller concave side used for low pitch sounds. These are going to be more of our abnormal sounds. So heart murmurs, bruits, low frequency sounds. Now that I said bruits, you may not know what that is, which we'll learn in our cardiac week, but a bruit is an abnormal blowing or swishing sound heard over an artery. It occurs when blood flow becomes very turbulent rather than smooth, and it's often due to like a narrowing, which is also called stenosis, or a partial blockage of a vessel. Then you have your diaphragm. That is where you're listening for normal sounds. So this would be like your heart sounds. We hear S1 and S2, which is your lub-dub. Again, we'll learn that more in cardiac. We're listening to our lungs and our bowel sounds. With the diaphragm, you want to press very firmly on the patient, whereas the bell, you want to press lightly. Common errors that we do see are listening over clothing. We never want to do that. Pressing too hard on that bell, you're not going to elicit the appropriate sounds. Not warming your stethoscope, moving too quickly when you're utilizing your stethoscope, and not comparing bilaterally. And then, of course, lastly is not cleaning between patients. So your biggest takeaways: do not listen on clothing and do not push hard with that bell. Okay. So now we've done subjective and objective data collection. So where are we at in this nursing care plan? So we are going to be putting all the findings under supporting data. And not all the findings, but all the findings that are pertinent to what we think is the primary concern. So we only have to put those ones there. We don't have to put anything that's quote unquote within normal limits or within defined limits. So we've completed subjective and data and objective data collection. Now what do we do? So next is analyzing cues and prioritizing hypothesis. So we've done number one in the nursing process. So we've done assessment. Now we're to number two in the nursing process, which is diagnoses. And then if you look over, I have circled under the clinical judgment model, number 2 and 3, which is analyzing cues and prioritizing hypothesis. So analyzing cues and prioritizing hypotheses. So this is when we're looking at what is that primary priority problem. So we as nurses must identify, need to look at the patterns, relationships, and abnormalities that require nursing attention. So how do we as nurses identify that priority problem? So first we'll cluster related data. So we'll group any cues that belong together. So for instance, if you have a patient that's having shortness of breath, crackles in their lungs, and a low SpO2, those are all underneath respiratory concerns. So we would group those all together. And then we really want to make sure that we avoid focusing on isolated findings, and we look for connections. Next, you need to differentiate between relative and irrelevant cues. So not all the data is going to be important for the current problem. So we need to ask ourselves, does this cue help explain the patient's main concern or current change in condition? So for instance, you have that patient that's short of breath, has crackles in their lungs, and then they have a low SpO2. Well, they also complain that their foot hurts. Well, we need to make sure, is that foot hurting irrelevant or relevant to the priority problem, which is their shortness of breath and lung concerns? And it probably is not. Compare to normal findings, so we do need to always make sure that we know what a normal finding would be, or within defined limits. We like to avoid the term normal, as normal is not something that everyone would feel the same. You know, your normal may be different than what my quote unquote normal is. So we need to be knowledgeable of within defined limits of our anatomy, physiology, and expected values to really recognize any deviations. So for instance, if you have a patient with a blood pressure of 88/54, well, their baseline may always be 120/80. So this is actually a significant decrease in their blood pressure, and that is not within defined limits, and it's not within defined limits for that patient. Next, you need to identify patterns or trends. So we're going to look for changes over time. Patterns are often going to reveal any deterioration in the patient's status or maybe improvement. So what's their urine output looking like if that's something we're monitoring? Is it decreasing, increasing? What are their vitals showing? Are they within those defined limits, or is it elevating or decreasing? We need to also consider the context. So cues having different meanings depend on the situation. So maybe a confusion in a post-op patient versus confusion in a stroke patient. A stroke patient may have more confusion than a post-op patient. It's things like that that we need to consider as what is happening in the patient's healthcare plan or plan of care right now. And then we need to validate data. So we recheck any abnormal findings and clarify subjective statements. So if we need to, we may need to reassess the temperature if it seems inconsistent with our other cues. So then once you've done these steps, you can then prioritize hypotheses. So that's interpreting and ranking possible problems or explanations. So we need to generate possible explanations. So what might be the cause of these cues? So if someone's having shortness of breath, could it be fluid overload, pneumonia, anxiety, a PE? And then we need to evaluate which is most likely. Use pathophysiologic reason to test each hypothesis. So example is, if you have crackles, edema, and weight gain in a patient, that may look more toward fluid overload and not anxiety. So we need to look at those other cues and know the pathophysiological reasoning behind it to really make those connections. Then you need to prioritize by severity and risk. So we have different frameworks. We can utilize the ABC framework, which we'll talk more about next week. ABC framework is your airway, breathing, circulation. We can also utilize Maslow's hierarchy of needs and seeing what needs they have within that hierarchy. And of course, those safety first principles. Next, you can consider what can be addressed immediately by nursing action. So some hypotheses require urgent intervention. So for instance, we have impaired gas exchange, while others need collaboration. So maybe there's an infection and it's requiring antibiotics. We are not able to just order antibiotics. We need to collaborate with our healthcare personnel. Anticipate complications, so we need to prioritize potential problems that could worsen quickly if ignored. And continually, we're going to be reassessing. Clinical judgment is very dynamic and not a one-time thing. And as a reminder, nurses cannot treat or make medical diagnoses. We just treat the client's response to medical conditions. So going a little bit more in depth, prioritizing and classification. So nurses, we need to constantly analyze and prioritize data collected during the assessment to determine if findings are urgent, important, or maybe routine. So we've got three different levels of priority. First, you have a high or immediate priority. So that's your first level, top tier, we need to address. These are mere life-threatening problems that require immediate nursing interventions. So is there an airway obstruction, respiratory distress, cardiac arrest, severe hypotension, maybe an active bleed from a trauma, altered level of consciousness, or maybe they are unresponsive? That is going to be more high or immediate priority. Again, utilizing those nursing frameworks of the ABCs, Maslow's hierarchy of needs, looking at that level of consciousness and pain. Then you have intermediate or second level priority. These are problems that are not immediately life-threatening, but may cause harm or complications if not addressed soon. So examples of this would be like pain, certain abnormal lab results. So for instance, potassium has a small like therapeutic window within defined limits. So if you have a low potassium, that is concerning, as well as risk for infection or risk for injury, changes in that mental status, new onset nausea or vomiting. So really as a nurse, we need to focus on prevention of deterioration or secondary complications, perform focused assessments to determine the cause, collaborate with provider if interventions are needed. So for instance, you have a patient that has a post-op, that is post-op reports of an 8 out of 10 pain, and their heart rate's 110. So we need to address that pain pretty promptly to prevent increased stress response and delayed recovery. But that's not a critical life or death situation at this point. That's why it's not a high level. Low priority is also called like ongoing or long-term. So this is where the problems that affect the patient's long-term health, maybe their education or psychosocial needs, and they do not require immediate action. So examples of this is maybe discharge planning, knowledge deficits, so teaching needs, psychosocial support, and coping and lifestyle modifications. So as a nurse, we really want to support rehabilitation, health promotion and education, encourage patient participation in long-term goals, address after immediate or secondary priorities are established. So then you have your nursing diagnoses, which is also what we will call a priority nursing problem. Nursing diagnoses are different than medical diagnoses. Remember, we as nurses, we do not diagnose. It's not within our scope of practice. So with a nursing diagnosis or that primary nursing problem, it's a clinical judgment about a client's response to actual or potential health problems. So we're going to base this off of assessment data that we've obtained, and then this provides a basis for selecting nursing interventions and planning care. So there's three types of priority nursing problems or nursing diagnoses. So the first one is a problem focused. Your second one is risk for, and then you have health promotion. So your problem focus, we're looking at what the current problem is and supported by what evidence. Risk for is there's a potential problem that the patient is vulnerable to, so they're at risk for developing. And then there's health promotion. So this is the desire to improve health and well-being. This is not as common in inpatient settings as being your nursing diagnoses. It's more within the outpatient setting and community. So there's three portions to the nursing diagnoses. You'll have your problem, that's your NANDA label. This is going to be in your care plan book, which we will do an interactive activity in class and will help make this more sense when we dive into your book. And then you have etiology and risk factors. So what is the cause? Why did you pick this as your problem? And what are those contributing factors? And then lastly, you have your defining characteristics and evidence. So these are going to be your assessment cues supporting that diagnosis. So let's walk through a quick example. So you have a patient, Mr. Jones. He comes with shortness of breath. His SpO2 is 88%, and he reports difficulty breathing. As the nurse, when we are doing our assessment, we may be thinking, this is a breathing concern or a breathing issue. So that is going to be a higher level of priority, like we just learned. Now we need to ask ourselves, like, why is he short of breath? What is going on pathophysiologically? Priority problem is likely going to be something to do with that airway and breathing. So then we would get out our nursing diagnoses book or care plan book and look for a NANDA approved nursing diagnosis that is related to that airway breathing, difficulty breathing that this patient is having. So we would conclude that from the book, there is one that's impaired gas exchange, and that would be aligning with what the patient is showing. So what could cause that? You would utilize the assistance of your book, and it will have that information that could potentially be linking the cause. So likely, let's say this patient it's related to alveolar capillary membrane changes. And then what are those defining characteristics or evidence? So what did we see in that patient? They are having that dyspnea, shortness of breath, SpO2 is 88%, and is complaining of difficulty breathing. So again, where are we in the nursing care plan? So this is where the arrow and the star are where you're going to be putting the highest priority problem and the priority problem. So your highest priority problem, it could just be like a list of like your ideas. Priority problem is going to be where you actually put that NANDA approved nursing diagnoses. Next, we have generate solutions or expected outcomes. So this is your third step in your nursing process, which is planning, or step number 4, which is generating solutions in your clinical judgment model. So generating solutions. So this is the process of identifying nursing actions or interventions that address a patient problem or nursing diagnoses. The goal is to be achieved through desired outcomes. And this is a critical thinking step that bridges that assessment and the diagnosis and evaluation. So solutions must be evidence-based, safe, feasible, and patient-centered. So we talked about in the last slide about Mr. Jones having that dyspnea and 88% saturation. Nursing diagnosis, we chose that impaired gas exchange. What can help with that? So what can we do to help that? So there may be choices or options in the nursing diagnoses book. So for instance, we could administer oxygen, position that patient upright, and monitor that SpO2. And we need to be aware when we are choosing these to consider the patient. We need to look at their age, their culture, developmental level. Do they have any comorbidities or what are their current medications? And then, of course, their patient preference and values. So then we need to identify evidence-based interventions. So utilizing clinical guidelines, protocols, and research. So we need to know the difference between independent nursing actions within that nursing scope of practice. We could do repositioning, education. Then you have dependent interventions. Those are going to require a provider order. And those would be such things as medications, maybe neb treatments, etc. Then you have your collaborative interventions. That's going to involve your interprofessional team, PTOT, dietary, maybe case management. And then, of course, always prioritizing your interventions based off those nursing frameworks, the ABCs, or Maslow's hierarchy of needs. And then with the image that's on this slide, we need to make our goals SMART. So these are specific, measurable, achievable, realistic, and timely. So then where are we at in the nursing care plan? So we are at the outcome for problem or the SMART. And that is where we would want to put SMART outcomes. So next we have take action or implementation. So in the nursing process, it's step number 4 is implementation, and then step number 5 in the clinical judgment model, that is taking action. So what will we as the nurse be doing? So with implementation, it's when the nurse will put the planned interventions into action. So it's translating planning into actual patient care. So we need to review and confirm the plan. So ensure that interventions are current, appropriate, and safe, verify client readiness and consistent, or obtain consent before taking action. We need to double check orders, equipment, and resources. Again, we'll prioritize everything based off priority need, utilizing ABCs and Maslow's. We do need to have evidence-based interventions that are supported by research, clinical guidelines, and best practices. Before the nurse can implement, the nurse needs to be competent. So competent is the specific rationale for the intervention. And then they must possess the necessary psychomotor and interprofessional skills. Then we as nurses function within a particular setting to utilize available healthcare resources effectively. All right, there are 3 different types of nursing interventions, and it would be good for you guys to know these. So we have nurse initiated, physician associated, and collaborative, which we kind of highlighted earlier in a few slides ago. So nurse initiated is what the nurse can do independently. It does not need to be done with a physician order, so a physician order is not needed. It's going to be based on nursing knowledge, experience, and judgment. And it also needs to be within the nurse's scope of practice. So we can do prevention, education, and provide comfort. So examples is educating the patient on deep breathing exercises, positioning a patient to prevent pressure ulcers, emotional support, or relaxation techniques. And then you have physician initiated. These are actions that require a physician's order. So it's based on a physician's response to treatment, management, or a diagnosis. Often medical treatments or prescriptions are going to be physician initiated. Nurses need to follow the provider instructions exactly. We cannot deviate off of these. So with medications, we need to know indication, contraindications, side effects. Those are things that we as the nurse will need to make sure that we are aware of before doing the physician initiated intervention. So examples, a physician assisted or initiated would be administering prescribed medication or IV therapy, ordering and performing any diagnostic testing, and initiating treatment per provider protocol. So maybe a wound care dressing. And then lastly, you have collaborative. So this is where it is required to coordinate with other healthcare team members. So that would be such as PTOT, dietary, respiratory therapists, social workers, or case management, and physicians. And this is where we're going to focus on more of the complex patient problem, and that's when we're going to need collaboration. So examples would be like coordinating physical therapy for mobility improvement, consulting a dietitian or dietary for diabetic meal planning, and collaborating with RT or respiratory therapist for ventilator care and management. So then next we have protocols versus standing orders. And is there a difference? And if so, what is it? So protocols are predefined, detailed plan or guidelines. So these are based on evidence-based practice and facility policy. They outline a step-by-step guidance for the nurses to follow, and it does allow nursing judgment as well. So it tells us how to and provides a standard of care within a facility, etc. So example, there may be a chest pain protocol. That chest pain protocol may say that we need to obtain a vital signs, EKG, administer O2, and then notify a provider. Then you may have sepsis screening or sepsis protocols where we're going to be collecting specific labs, IV fluids, and monitor vital signs. A lot of these protocols you will see frequently in the emergency department or urgent care settings. And then you have standing orders. Standing orders are pre-written physician orders that authorize the nurse to perform certain interventions. And that's done automatically. They're in there, we can do them. Legally authorized, and they need to be signed by a provider though. This is again going to be common in the emergency room. We'll see this with certain medications and med admin, lab draws, and immunizations. This is going to tell us what to do. So for instance, there may be a heparin sliding scale. For cardiology, per se, there's an uncomplicated UTI treatment standing order where we would administer certain medications or start an antibiotic. Then there's administering like a medication. So for instance, a medication may have the order administer acetaminophen, 650 milligrams orally for a fever over 101. So then we as the nurse, when we take the temperature, if it's above 101, then we can administer this medication. And same with oxygenation as well. Sometimes there may be a standing order that you give 2 liters of O2 via nasal cannula if the patient's SpO2 goes below 92%. Then we have direct and indirect care that can be provided as part of those nursing interventions. So direct care, that involves nursing actions performed with the patient, which have physiological, psychological, or therapeutic impact. So these are going to be more hands-on or face-to-face interactions. It affects the patient immediately or directly and can be physical, emotional, or psychosocial care. Examples would be administering medications or IV fluids, assisting with activities of daily living or ADLs, like bathing or feeding, monitoring vital signs, wound care, or inserting a catheter, and teaching the patient about disease management or medications. So again, direct care is central to patient outcomes, requires skill, critical thinking, and assessment. And then we need to make sure that we document the care provided and the patient's response. Then you have indirect care activities. This involves nursing actions performed on behalf of the patient or to support the environment, healthcare team, or documentation, but it's not directly impacting the patient. So key features of this is we're supporting direct care or overall patient safety. So this may be planning, communication, and coordination. Examples, documenting patient care with an electronic health record or the MAR, communication with healthcare providers about the patient's status, managing the patient's environment, so equipment setup, infection control. This also would include delegating tasks to an unlicensed assistant personnel like a PCT or an MOA, reviewing lab results, ordering supplies, or updating care plans. These are things that we don't have to do directly at the bedside. Teaching points for you guys would that we need to make sure that we are still keeping our patient in the loop of what is going on. And this helps facilitate, the indirect care helps facilitate effective direct care and patient safety. So next we have when writing a nursing intervention, the nurse is going to need to include what components. So the 4 components is what, when, how, and who. So first, what? So what will the nurse do? So this is going to be the actual action. We need to make sure that we're utilizing specific action-oriented verbs like assess, monitor, teach, administer, reposition. And we want to avoid vague terms. Vague terms would be care for, help with. Well, what are we helping? What are we caring? Next, you have when. When would be the frequency the action will be performed and or under what conditions. So example would be reassessing pain level 30 minutes after administering a narcotic, or encourage coughing and deep breathing every 2 hours while awake. So it's that 30 minutes after every 2 hours. The nursing intervention does not have to be solely performed by a nurse. We can also delegate some of the interventions to an appropriate healthcare professional. So that is when we would add that into the who. How will it be done? How will the intervention be implemented for this patient? That's step number 3. So we want more specific. So example would be assist the patient to turn every 2 hours utilizing a 2-person log roll technique. So that 2-person log roll technique is how it will be done. Or another example is teaching the patient to utilize incentive spirometer by demonstrating and having return demonstration. So that demonstrating and having return demonstration, which is also known as teach back, is that how. So then lastly, who is the nursing intervention for and who should be in each aspect of that intervention? This is where certain things can actually be done by the UAP or the MOA/PCT. So the nursing intervention will always begin with typically the nurse will. Even if delegation occurs, you'll put the nurse will delegate and then continue that nursing process. We want to avoid very generic interventions. So there's an example in the STAR. So the nurse will turn the client every 2 hours as follows: 0800 supine, 10 a.m. left side lying, 1200 right side lying, and 1400 left sims. And as a friendly reminder, nursing interventions always begin with the nurse will. So then where are we at in that nursing care plan? So in the third box over, we have interventions. Of course, we want to include that rationale, and there's a list of at least 3. As a reminder, I have down there the nurse will is how it'll start. Make sure to include the what, when, how, and who. So next we have taking action. There are 5 preparatory activities in order to implement the process. So before the nurse performs any intervention, we need to do these 5 things. We need to reassess that client. Always reassess the client immediately prior to implementing an intervention. Why would we do that? Because conditions can change rapidly, and reassessment ensures that intervention is still appropriate. Then we have reviewing and revisiting the existing nursing care plan. So we need to review that care plan to ensure it reflects accurately with the client and their current priorities and status. And then we can revise the interventions or goals if the patient's condition or needs have changed. Number 3 is preparing for implementation. So making sure that we're getting everything organized, gathering all necessary equipment. This all just helps save time and prevents any safety hazards. And then number 4 is anticipating and preventing complications. So we must utilize our critical thinking to identify any possible risks or complications that may occur. We need to plan how to prevent or respond to those risks or complications quickly, and then assess the patient's specific factors. So looking again at allergies, comorbidities, or tolerance. So an example would be before ambulating a post-op patient, assessing for dizziness, hypotensiveness, or confusion, and making sure that we have assistance ready if something were to go on during our intervention. Implementation of the intervention. This is where you confirm you're following correct procedures and you're practicing within your scope of practice. So ensuring that patient safety, infection control, and ethical care is being provided. And then provide explanation to your patient. So what are you doing and why are you doing it? It's really important to always keep. So then our final step is evaluation. Why do we evaluate? We're going to evaluate to measure the effectiveness of nursing interventions. Is the patient goal and expected outcome met? Identify needs for revision of that plan of care and ensure accountability and quality of nursing practice. So again, evaluation is that final step. So when we do an evaluation statement, we'll begin with the outcome was met, not met, or partially met. So we need to examine the results and compare the achieved effect with the goals and outcomes. So we're going to gather subjective and objective data again and compare the current findings to those baseline findings or expected outcomes. And then we need to interpret and summarize the findings. So was the outcome met, partially met, or not met? We're going to look for patterns or trends in that patient response. We're going to utilize critical thinking to decide if improvement is due to our nursing action or another outside factor. And we don't want to just ask what happened, but ask why it happened. We want to recognize errors or any unmet outcomes. We need to identify barriers or factors that may have attributed to the success or even the failure of our outcome. So such as, was there patient adherence, environmental factors, a knowledge deficit, incorrect nursing intervention or frequency. And any unmet goal is simply feedback. It's not failure. It just shows where we as nurses can improve for the patient. And then we need to make sure that we correct errors and revise, continue, or terminate the plan of care. So if the outcome is met, we'll continue those interventions, maybe even doing a new goal. If partially met, do we need to modify interventions, timing, or teaching strategies? And then if it's not met, we can reassess the data, revise the nursing diagnosis, and even develop maybe a new plan. So evaluation will go in the very last box of the nursing care plan. So this is where we will put the statement, the outcome was met, not met, or partially met, and then provide a rationale that made us come to that conclusion. So we'll have a recap and wrap up and some friendly reminders from this presentation. So clinical judgment model is aligned with the nursing process. Those two are aligned. The nursing process and clinical judgment models are really the frameworks for how we think as a nurse and thinking through the patient problems. The process of the clinical judgment model and nursing process is very flexible and it is ever changing. It's not rigid. Again, nursing is very gray and it's not always black and white.